about training because the world is shifting a little bit in this area. We'll talk about some of the pathological appearances we're used to seeing, and then something on advanced ultrasound, and that's really the main part of the talk. Pneumothorax assessment, M-mode, pre-thoracoscopy pneumothorax induction, real-time techniques, and intercostal artery detection. And this is a very fast-moving field with a lot of new data coming out in the last 5 years or so. So first of all, if we get the basics right, ultrasound has very strong data in its use for the detection of pleural fluid. It is better than a chest radiograph. It has a higher procedure accuracy than using clinical examination. It has a lower complication technique, and it gives us added diagnostic information. And all of this we have known for at least 20 years. So none of this is particularly new. What is new in the last 15 years or so is some of the more direct data. And I personally feel, and you may have your own view, that it is now really not proper to conduct a pleural intervention without ultrasound. Now, why do I say such a strong statement? The real reason are these two studies, and I'll just go through them in some detail. So this was a study by Andreas Diakon in South Africa. In this study, he took patients who had chest x-rays that looked as if they showed pleural effusion. He asked pulmonologists to examine the patient, and he asked them to make a mark on the skin where they would insert a needle to achieve a pleural aspiration. What he then did was, in the same position, he then conducted a thoracic ultrasound, and he demonstrated that 1 in 6, 15% of clinically identified puncture sites were inaccurate, and without ultrasound, the puncture would have resulted in organ damage in 10%. So this is a direct comparative study. I don't think we need a further study to show us the use of ultrasound, telling us very strongly that thoracic ultrasound is better than clinical examination. And one of the beauties of this study is that it did not matter whether the physician who was examining, these physicians, whether they were very junior or senior. Even the junior ones, even the very senior advanced consultants, their clinical examination was still incorrect in 15% of cases. So it tells us without question we should be using ultrasound. So this is a small scale direct comparative study. And then we move to the large scale comparison. So this was a study done in the United States, 61,000 thoracenteses, 47% without ultrasound, and using multivariate modeling, they predicted what factors result in complication. And the fact is that lack of use of ultrasound causes complications of pneumothorax in 19%. So we have small scale data and large scale data that to achieve thoracentesis and to do safe interventions for fluid, ultrasound is absolutely mandatory. And this, I believe, is the way that we as pulmonologists should all go. I would feel very uncomfortable achieving a pleural intervention without ultrasound in the modern age. Now, let me briefly talk about training in thoracic ultrasound, because I think this has historically been badly done. We in the UK were training according to the Royal College of Radiology guidelines, which I haven't included here. And these were, one must understand, guidelines written by radiologists for pulmonologists. But this piece of work, which I helped to push over, but I wasn't involved in directly, is the British Thoracic Society writing a training standard for thoracic ultrasound. So finally, we now have access to a specialist document written by us as pulmonologists in how people should train in thoracic ultrasound. And I very much recommend this as a piece of work. It's free to access on the BMJ Open Respiratory platform. In parallel to this piece of work, the European Respiratory Society has created a curriculum and a training guideline in how to become competent in thoracic ultrasound, and I'm involved in that process as well. So we have finally taken this skill away from our radiology colleagues such that we can now deliver it and train it ourselves. And this makes some sense. The reason it makes sense is we audited in the UK how many thoracic ultrasounds were done by radiology compared with how many were done by pulmonology. And the split in the UK last year was 90% were done by pulmonology and only 10% were done by radiology. So this is very much a technique that belongs to us and that we now have the expertise rather than the radiologists. Just to give you a flavor of this document, this is, we split competence into the very basic. So this is the emergency operator pathway. And I won't leave it up for too long, but you can see the simple fact is these individuals need to know the basics of ultrasound and can identify a large effusion and identify a safe spot for insertion. So that's right at the bottom of the training ladder. And right, all the way at the top of the training ladder was what we call the expert operator. And this meant that they needed to do 70 ultrasound examinations per year. They could use advanced modes such as M mode, comment on diaphragm function, obtain pleural biopsies, use ultrasound for pneumothorax induction. And a lot of my talk will be about this more advanced area. So we can see that we are developing a very good training pathway that goes all the way from perhaps the emergency physician who needs to just identify fluid, and they can be at a certain point, compared to the expert pulmonologist like my friend Muzaffar Matintas, who would be considered an expert thoracic ultrasound operator. So let's move beyond ultrasound as a diagnostic tool, beyond fluid, because we're all very familiar with its use as a diagnostic tool for fluid. Can it do more for us? Well, here are three diagnostic areas I think we should think about. The first is the presence of echogenic swirling. The second is diaphragm assessment in patients with pleural effusion. And the third is pleural thickening or nodularity. And I'll handle them one at a time in the next few minutes. So this is a very typical ultrasound. All of you are familiar, I am sure, but just so we are on the same page, here is the parietal pleura, here is the chest wall, here is the diaphragm, and here is the visceral pleura with a large amount of fluid in between. All of my ultrasound images will be in the correct orientation, which means the head is at this end and the feet are at this end, and this means this is abdominal content and this is the lung here. So a very large effusion, but you can see the little white dots moving around within the fluid, and this is known as the echogenic swirling sign. And there's been interest in what this represents. What does it really mean? The received wisdom is that it means that this must be an exudate. It must be said that fluid that is black completely, perhaps like this, that can be either exudate or transudate. And many people have said that this represents the small protein molecules or the small little areas of fibrin, and therefore this must be an exudate. So the question is that true? Well, this was a piece of work that one of my fellows, Rochelle Ashiak, did and published in Respiration last year. We prospectively assessed the ability of ES or echogenic swirling in 140 patients to signify whether something was a transudate or exudate. And in terms of separating transudate and exudate, the positive predictive value was 90%, but not 100%. And therefore, even a few, 10% of patients with echogenic swirling, in fact, had transudative biochemistry, and it was very poor in terms of sensitivity. So it can be used, but it mustn't be the be-all and end-all test. If you see echogenic swirling, it is very likely to be an exudate, but this is not a complete diagnostic modality on its own. And some things that look echogenic may well turn out to be a transudate. The other way around, it was very useless. So you cannot say it is non-echogenic and therefore it must be a transudate. This doesn't work at all. So that's some decent data that tells us how to use the sign of echogenic swirling. Perhaps more interesting than this was this piece of work done by my colleague Majid Hassan when he was with us. And this was looking at the relationship between echogenic swirling and whether it predicted whether a patient had a successful pleurodesis. So it was a small study, and this study doubtless needs repeating. I hope people on the call will try and repeat the study. We only had about 37 patients in the study, but we divided them according to whether there was echogenic swirling positive or negative. And then we looked at whether these malignant effusion patients had a successful pleurodesis. And you can see that echogenic swirling correlated very closely with pleurodesis failures. So if echogenic swirling was present before the intervention, then the pleurodesis failure rate was in the region of 80%, 75%. Whereas in successful pleurodesis, it was present much lower, and the chi-squared value was extremely positive. And therefore, it may be that echogenic swirling helps us to predict which patients will have a pleurodesis success or not. Now, I don't understand the mechanism. I don't know why. It may be that echogenic swirling correlates with a higher LDH, and we know that a higher LDH correlates with pleurodesis failure, but this is a rich vein for future investigation. Now, here is another aspect that we get from the same ultrasound I've shown you before. Echogenic swirling is present, yes, but the diaphragm is abnormal in two ways. One, it is inverted, And the second is that it is moving paradoxically. So on inspiration, it is moving upward rather than downward. And for a long time, clinically, we have observed that this is associated with a large amount of symptoms. When we remove fluid, and in this case, we removed about 2 liters of fluid, this is what occurs. The diaphragm pops up, it takes on a normal conformation, which is what we want, and it's starting to move normally as well. Now, I'd like you to note that the effusion is still present. There's still at least a liter of fluid here, and the lower lobe is entirely atelectatic. And yet, despite the lower lobe being compressed, the patient feels much, much better. So the question becomes, can the diaphragm formation on ultrasound and its response to drainage, can that predict whether a patient has a good response to your therapeutic aspiration, to your thoracentesis? And we now have this study, which I think helps us to confirm that. So this is a great study done by Gary Lee's group in Australia. And they essentially prospectively looked at near on 200 patients undergoing pleural fluid aspiration and measured a load of physiological parameters and correlated it with breathlessness and the relief of breathlessness. So 145 patients, symptomatic, all of them were, and then they assessed them pre and post drainage, and they measured, as I've said, breathlessness, quality of life, radiology, and their spirometry. Now, what they found is very, very interesting indeed. So the majority of patients had a very significant improvement in their breathlessness. So the visual analog score, the VAS score, is measured out of 100. In Australia, a lower score is worse, a higher score is better. And so they improved their breathlessness from 43 to 72, a huge improvement in breathlessness in these patients. And this was obviously reflected in the rest of their assessments as well in terms of improvement in breathlessness. Interestingly, the functional capacity was slightly improved, not hugely, and there was some improvement in the cardiorespiratory parameters. The respiratory rate went down. The spirometry, unsurprisingly, got better, but very slightly better. So the mechanism of improvement of breathlessness is definitely not related to the spirometry. This is a very small gain. In asthma management, we would not be very impressed with this amount of gain, less than 10%, and yet their breathlessness improves hugely. So what's driving the improvement in breathlessness? Well, in their study, they showed that it was related to the ipsilateral hemidiaphragm movement. So they found that the movement was abnormal in half of their patients pre-drainage and back to 94% normal after drainage. And this was an independent predictor of whether the patient had breathlessness relief. So finally, we've got to the stage where if a patient is breathless and we drain the fluid, we have a predictor of whether they're going to improve. The 2 predictors that are important in my view are, one, that they are breathless before drainage, and secondly, if the diaphragm is abnormal. These 2 help us to understand if the patient will achieve any relief in breathlessness. And there is ongoing work looking at slightly closer, slightly more finesse diaphragm assessments, M mode, fractional shortening, looking at whether we can be even better at this than we are already. So that's an exciting area for future research again. Now, what about other diagnostics? So I've given some still images here. This is obviously the diaphragm. Here you've got a large nodule sitting on the diaphragm. Here you've got a large amount of nodular pleural thickening and a discrete pleural nodule. On top, you have visceral nodularity. Can we use ultrasound as a purely diagnostic tool? Can it predict who has a malignant pleural effusion? Well, this is a study that I did with Fergus Gleeson and Agni Qureshi many years ago now, so more than 10 years ago now, we conducted this study to try to answer that question. We took 52 patients, we scanned them, did a full thoracic ultrasound of the whole hemithorax before their diagnosis was established, and then we compared it to the CT and the final clinical diagnosis, largely obtained at thoracoscopy. And this is what we found, and I'm not going to go through it in great detail, but essentially ultrasound was showing parietal thickening more than 1 centimeter, showing nodular pleural thickening, diaphragmatic nodularity, diaphragmatic thickening more than 7 millimeters, and then the presence obviously of liver metastases were very, very correlated with the patient having a malignant pleural diagnosis. And this gave ultrasound, using all of these features, a sensitivity of 79% and a specificity of 100%, which is really very good in terms of a diagnostic radiological measurement. Now, how does it compare to CT? Well, we all use CT. We all use CT on the Leung criteria. And you'll see here in the same study that in fact the sensitivity and specificity of ultrasound was comparable, if not better, to that seen using CT. Now, why have I put not applicable in these three boxes here? The reason is that the CT cannot see the viscera very well, it cannot see the diaphragm very well, and it can't see diaphragmatic layers being resolved. But all of these had extremely high specificity for a patient with malignant pleural effusion. So if you see a patient with parietal thickening more than 1 centimeter, nodular thickening, visceral thickening, diaphragm more than 7 millimeters, you cannot resolve the 5 layers of the diaphragm and diaphragm nodules, then they are very likely to have a malignant pleural effusion. And I think this is very helpful because we scan patients in clinic and we triage them to the next diagnostic test. And I think ultrasound is a very good way of doing this. Now, this study has been repeated. This was repeated by the group in Germany, and they did pretty much the same study, but in a larger cohort. So it's a more powerful study than the one that we did. And they found pretty much exactly the same things. And I won't go on about this. You can look up the reference, and I'm happy to share my slides. But again, the presence of chest wall invasion, lung lesion, or hepatic metastases had a 100% positive predictive value, but the overall yield of ultrasound was 83%, really a very good test for diagnosing malignant pleural disease. And they then did logistic regression to look at which independently predict the possibility of malignant pleural disease. And it was the pleural or diaphragmatic nodularity that was the one that came out as the strongest individual predictor with an odds ratio of 29. Now, I will point out that the confidence interval was very wide, 7.6 to 110. And the reason is that the numbers of patients in the study was not that large. It was bigger than ours, but it wasn't that large. And that meant, but this gives you a nice little menu of the independent predictors of malignancy on thoracic ultrasound. So I would use pleural diaphragm thickness, pleural diaphragm nodularity, and then the lack of the lung air bronchogram sign. So does this work? Well, here's a direct example of how it works. Now you can read this ultrasound the same as me now. It's echogenic swirling, likely to be an exudate. This is the diaphragm, and there is a nodule sitting right on the top of the diaphragm here. This is the top of the parietal pleura. Here is craggy looking parietal pleural thickening. This looks malignant. And there is something sitting in the costophrenic recess that's pistoning in and out. This looks like a nodule as well. So we would predict very strongly that this is a malignant pleural effusion. This particular patient, we proceeded directly to thoracoscopy, and this is what we saw. And you can see exactly what you see on the ultrasound. So here's the nodule on the diaphragm. Here's the nodule in the costophrenic recess. And here is the craggy pleural thickening that we can see exactly the same as the ultrasound. This is looking up towards the apex, and this was a case of advanced lung adenocarcinoma, as you can imagine. Now, there are some new tools available to us. What I've talked about so far is really quite old, the recognition of nodularity and so on. And this, I think, is a key area of future development. So ultrasound elastography. Now, this is a novel tool for us within the pleural space. This has been used for many years by our colleagues who do liver ultrasound, for example. Simply put, this interprets the movement of a tissue according to the ultrasound waves going through it. And according to how elastic it is, how much it moves with the ultrasound waves, you then get a score, which is really the speed with which the ultrasound wave is traveling through a tissue. And our colleagues within the hepatic world have used this to identify malignancy like hepatocellular carcinoma for a long time. And this group, who were based in China, did this really nice study. It's the only one in the literature to date. 2019 it was published. It has been replicated since. So what did they do? This was a 244 patient study. It was extremely well designed. It was prospective, and they conducted thoracoscopy in the patients to get a diagnosis. And what they did was they developed and validated this SWE, which is the pleural shear weight elastography. And so that's what I'll refer it to as SWE. And this was an interpretation of how quickly the sound waves were moving through any pleural thickening. I would point out before we interpret the study that their prevalence of TB was extremely high. So in the UK, in Oxford, this would be less than 1%. In their area, it was 20%. And I think that does affect how we interpret their findings to some extent. Now, I'm showing this because I thought the development of this study was really very neat indeed. And they had two separate parts to the study. They firstly did a development stage between 2012 and 2016, when they assessed 137 patients, generated a ROC curve, and then they prospectively assessed the ROC curve, you'll see here, from August 2016 to October 2017 in 152 patients. So this is truly development and validation in a single study, which is very praiseworthy and means that we can have some confidence in what they found. And I like that in terms of the design of the study. And this is an example of their elastography. So this is pleural thickening, as I've shown before, with a linear probe here as well. What they then do is to put the special Doppler box on and then calculate the SWE. And you can see here it's measured in kilopascals. 41.4 kilopascals is an interpretation. They were careful not to put the Doppler box within the fluid, because obviously the fluid is moving very freely with the cardiac pulsation. Now, this is a very busy slide, and I don't need us to look at it for very long, but you can see that the overall sensitivity of the SWE mean was 91% for malignancy versus other TUS findings, like in my study, of only 57%. So it far outperformed TUS in general, and it seemed to be highly sensitive and highly specific in the development set, and in the validation set, it was similarly highly sensitive and highly specific. So this looks like the shear wave elastography looks like a very good way of diagnosing malignancy if it's proven in other areas. This was their ROC curve. So this is the sensitivity and 1 minus specificity of malignant diagnosis using the mean or the max SWE. And you can see this is the perfect ROC curve, extremely sensitive, extremely specific. And so just before I go on, I think this might be an exciting area for us to investigate in the future in different populations. I think it is important to recognize that a lot of their patients had TB, and it may be that TB is easy to differentiate from elastography versus other, for example, non-specific pleuritis, and that needs further investigation. Let me just talk very briefly in a few slides about pneumothorax, because I think this is a misunderstood area in terms of ultrasound. How good is ultrasound in diagnosing pneumothorax? Well, if you go to the literature, it appears to be extremely sensitive, extremely good, and detects occult pneumothorax. What does occult mean? It means it's not present on a chest X-ray, but is present on a CT. So a quick reading of this literature would lead you to believe it's the perfect tool. Actually, I don't agree with that, and I'll explain why. Firstly, the majority of these studies were done by radiologists, and several of them were done pre and post lung biopsy. And it's very different to doing an ultrasound where you know the appearance normally, and then half an hour later, the appearance has changed. So that's different to diagnosing pneumothorax without any prior knowledge of what the ultrasound looks like. It has advantages. It's more sensitive and specific than a chest X-ray, but as you will all know, it cannot quantify the size of the pneumothorax. It can only tell you it's present or absent. And then here is the major problem that I have. So this was a study done by radiologists here in Oxford, now nearly 15 years ago. And what they did was they looked at ultrasound in its ability to diagnose pneumothorax, and then a control group and a group of COPD and a group of cystic fibrosis. And you can see that in the COPD group, patients were very commonly abnormally assessed as having pneumothorax when they didn't have pneumothorax. Now, why is that? The reason for that is this is a large bulla, and on a bulla sonographically behaves exactly the same as pneumothorax. It's air and it doesn't move. So the one situation where I as a pulmonologist want a tool to tell me, is this a pneumothorax or is this a bulla, the ultrasound is no good. And in my opinion, I would always use a CT to decide for difficult pneumothorax. If the pneumothorax is easy, I would use a chest X-ray. The only time I use ultrasound for pneumothorax is on the intensive care unit as a quick screen. I don't use it otherwise. And obviously this is the bullous that's seen on that previous chest X-ray. And just for interest's sake, this is what pneumothorax looks like. So this is normal lung sliding with a curvy linear probe. You can see the A line and multiple B lines. No doubt that pneumothorax is not present on this scan. If we do this on a linear probe, you can see the detail in a much more fine way. There's cardiac movement and there's also respiratory movement. This must be normal expanded lung with 100% sensitivity. Now, the same patient inducing a pneumothorax, it looks very different. Okay, let's move on to real-time image guidance then. So what do I mean by this? When you're conducting a pleural intervention, you have two options really. One is to mark the skin, so scan put the probe down, and then conduct your intervention using the mark that you have made. This has advantages. It is simple, it avoids expensive equipment, but there are problems such as movement of the patient and delay. And specifically, if you mark where the effusion is and then send the patient to another ward to have the intervention, that is actively dangerous, because when the patient moves, the cross can move easily over the liver or over the lung. So this is not something that we should be doing. And in fact, we have data from this very good study, now 30 years old, in which they did exactly this. They marked on the skin and they then sent the patient elsewhere. And you can tell that the complication rate is the same doing it in this way as if you didn't use ultrasound at all. So there is no point doing this. Please do not mark the skin and then wait to do the intervention. You should do the intervention in real time straight away with somebody who's competent at ultrasound. Now, the alternative is real time, and that's very much my preference, ultrasound or direct vision. You can see what you're doing. It is more difficult to learn and it requires specific equipment, but I think it is a skill worth having, and I'll show you why. So this is the equipment that you need. It's an inline technique. You need some form of sterile sheath. It's a fully sterile procedure, of course, and it does require a freehand technique, which does take some skill to learn, but it is very teachable, very learnable. So here's an example. This was a patient who had a pleural infection. You can see that they've got multiple locules, and this is the largest locule which we specifically wanted to place our chest tube in. And the only way of achieving this is with a real-time technique. I'll show you what we did. So this is the local anesthetic needle. You can see the bubbles of local anesthetic swirling around within the larger locule. We then place our guide needle, and I deliberately puncture 1 and then 2 septations to achieve the largest area. Once we've achieved the largest area, I can then pass my wire, and you can see the J-tip of the wire just here. So I'm very confident that the wire is in the largest area. And having passed my tube over the wire, I then flush with saline, and you can see what happens. The bubbles of air are within the largest locule. And this is really only achievable with a direct vision technique. Here is another example of a patient having with a very thick pleural collection. This was frank pus, and it was very difficult to know where we had ended up. This is the tip of our needle, and you can see the wire with its J-tip being withdrawn. So we are very confident of where the drain is going to be. And this was a particularly difficult insertion in which we had some consolidated lung right next to our entry site. And what we're doing here is we are pushing the wire in to bounce off the lung to make sure that we're not directly going into the lung here. It would be very easy to accidentally drift within the lung and cause a pneumothorax and a problem. Okay, that leads us nicely to image-guided biopsy, which is part of, I think, the horizons of where we should be moving with thoracic ultrasound. What are the indications? Well, patients who have pleural thickening, of course, malignancy and TB, we use it if we have failed to cause a thoracoscopy because the pleural space is pleurodese or we can't induce a pneumothorax. And we increasingly use it for patients who are not fit enough to undergo thoracoscopy as well. And here's a beautiful example of a large amount of pleural thickening, tethered lung and a pleural effusion. And here, a thoracoscopy, unless with a very advanced operator, is not going to work because your operating space is this big. And what we need to do is to sample this. And an image-guided biopsy is a perfect way of doing this. What's our evidence? Well, a blind Abrams biopsy has a very poor yield. I think that's well accepted now, and randomized data tells us that. And we know that it's fairly good in TB pleuritis, 80%, but in malignant effusion, it really isn't very good. What about randomized control trials versus image-guided biopsy? Well, we've got 2 RCTs demonstrating the superiority of CT-guided biopsy versus blind Abrams biopsy. Abrams gets you very good tissue, and in fact, Professor Matintas's study has shown that. I'll go on to talk about that in a second. Now, ultrasound versus CT biopsy for lung and pleura shows very similar diagnostic yields in this large study done in radiology. So it does appear that ultrasound-guided biopsies are probably just as good as CT biopsies in selected patients. Now, this I think is the best study in the literature because it's a randomized controlled trial. It happens to be authored by my colleague, Professor Matintas, but I will mention it nonetheless. So it's a 150 patient study. And this was a very novel study, ultrasound guided cutting needles that I've spoken about already, versus a CT-guided Abrams. So, and that's important because the CT was conducted, the place best to do the Abrams biopsy was then identified, and then the Abrams was done. The ultrasound was conducted, and then the cutting needle biopsy was placed, but not with direct vision in this particular study. And you can see the trial scheme here. 150 patients were randomized, 75 into each arm, with very, very good data completion. And here is the headline. The sensitivity of CT-guided Abrams biopsy was 82% versus a sensitivity of 67% with ultrasound cutting needle biopsy. So clear superiority for CT-guided Abrams biopsy. Now, why was this? Well, there's a couple of reasons. The Abrams biopsy performed correctly, which clearly Professor Matintash and his colleagues did so, achieves large amounts of pleural tissue, and it was guided by CT and therefore was probably more suitable for areas which had specific particular nodules of pleural thickening. With the ultrasound guided biopsy, this wasn't done real time, that's fine, but also if there was no pleural thickening, then the ultrasound was a little bit lost and the CT had an advantage there. So I think that's a very interesting result. And this was borne out within the subgroup analysis. So this is the same result. All cases, 66% sensitivity versus 82%. But if you looked at those with pleural thickening, then CT biopsy has a big advantage. Less than 1 centimeter of pleural thickening, ultrasound biopsy is really very poor. If you've got pleural thickening, then they are much more similar. And I think that's a key message in terms of your practice. If there is no pleural thickening, then the ultrasound guided biopsy is really not a very good test. If there is pleural thickening, it's a good test. The CT guided Abrams is good in either situation. Okay, so as I've said, very good randomized study, clear difference between CT Abrams and ultrasound cutting needle, and the increased yield in the thickening more than 1 centimeter is a key practice point. Now, other studies, including this study that was done by my group, have shown a higher diagnostic yield using cutting needle biopsies. This was not a randomized trial, and that's important to recognize, but we achieved sufficient material in 94% and a diagnostic yield of 92%. Now, why is there that difference? Well, there's two reasons. The first is this was a selective study of patients who failed thoracoscopy. And why did they fail thoracoscopy? Because they had pleural thickening and pleural adhesion, and therefore this is 1/2 of Professor Matintash's study. So that's the reason it was better in that sense. The second reason, in my opinion, is that we use a direct guided technique where we watch the cutting needle into the pleura. And I think that might have some differences, but it will be interesting to discuss that in the question afterwards. And then this second study I'd like to highlight. So this is Connie Kogelenenberg, who's a colleague from South Africa. He adopted a new way of looking at this, which was a prospective 100-patient study where the ultrasound was used to select which pathway to go down. And his study, in summary, I'll show you the trial scheme in a second, altered the diagnostic yield from 1/3 to over 90%, which is really very impressive. So this is what they did. They took ultrasound first, and on the basis of the ultrasound, decided what they should do. So if there was no pleural thickening, they did a repeat thoracentesis and then an ultrasound guided Abrams. If there was pleural thickening, they did a repeat thoracentesis and then an ultrasound guided Abrams or cutting needle biopsy. And if there was a pleural base mass, they did an ultrasound guided transthoracic needle aspirate and a cutting needle. And then all those that didn't get diagnosed ended up needing to have a medical thoracoscopy. And you can see here that using this triage system, the malignant pleural effusions were diagnosed in 90% of cases. Now the numbers here are small, 24, 18, 10, not very large. And you can see also they have a large number of TB cases here as well. So some decent data that ultrasound can help not just to do the biopsy, but to tell you which biopsy to do, which I think is a very intelligent way of approaching it. And then the best study in this area, I think, again, is by my colleague, Professor Matintash, who did this study. Now, to be very transparent, I'm also an author on this study. That was very kind of him and his group, but nonetheless, I think it still is the best study. What did they do? They used CT to triage, and they used CT features to triage into 3 different categories. So that was category A, pleural lesion and effusion, category B, pleural effusion alone, and category C, pleural thickening alone. And according to the categorization, they then did biopsies accordingly. So Category A, pleural lesion and effusion, was a CT-guided Abrams, as shown in the previous study. A pleural effusion alone had a thoracoscopy, and pleural thickening alone had an ultrasound-guided cutting needle. And so this is the trial scheme, that in each case, if there was fibrinous pleuritis, they would move on to medical thoracoscopy. It was a very well done study in that if there were risk factors and a negative diagnosis, either the patients underwent prolonged follow-up or they went on to have a surgical biopsy. So the ground truth was very well achieved in this particular study, and we can have confidence in the results. So this was the flow of patients, approximately the same number in these two arms and smaller numbers in the ultrasound cutting needle, probably because there are less patients with pleural thickening alone. And what I would highlight is this top line here. So using CT as a triage method and having skilled operators doing these three different techniques, the diagnostic yield was incredibly high, above 90%, and no other study has shown such a high diagnostic yield. And I think there's a really important practice point here, which is a combination of a skilled biopsy method, three different biopsy methods, in fact, but a CT triage. This is probably the best way to manage pleural disease, in my opinion. And I think we should all be following this. And I'm sure that this will move its way into the guidelines in terms of how one should approach patients with pleural disease. Just very briefly then, for those of you who don't use the cutting needle, this is an example. I'm not a particular advocate of one company or the other. I think they're all exactly the same. Essentially, they're spring-loaded with an open face just here. So this is in the closed position. One moves in towards it under ultrasound and then extends the needle so that the open jaws are within the lesion. Then press a button at this end, that's this orange piece here, and that causes the spring-loaded jaws to fire. And then this is the bit that's biopsied. So it's a really very fine technique. And here's an example. So this was a patient with a septated effusion, very small space. We couldn't get in with thoracoscopy. So what we do instead is to insert a cutting needle under direct vision. And you can see its shaft here. I'll play the video again if it does. You can see that we're inserting the shaft here. So we guarantee, this is the tip here, we're guaranteed to be crossing the pleura here, and we will definitely sample the pleural abnormality just here. Here's a really even nicer example. So you can see the whole shaft here. At this point, we are opening the jaws. This is the end of the jaw. This is the beginning. The jaws are now in the fluid. So we withdraw it and we take the biopsy. And with this real-time direct vision technique, you can definitely biopsy anything that you can see. So how do we conclude? Well, I think ultrasound biopsies have a very high diagnostic yield. High quality studies, including RCTs, will inform our practice. I believe real time has big advantages. And I think that either ultrasound or preferably CT to triage your biopsy strategy is likely to be the most rational way forward in our future practice. Okay, let me move on to the next area, which is pneumothorax induction. And this is specifically for those of you who practice thoracoscopy. So why would we want to do this? In patients who have minimum pleural thickening and not much effusion, one needs to create an operating space. And in order to do that, we use these needles, which are referred to as Butan needles. So this is a needle with a sharp trocar, but a side port. This is very carefully inserted into the pleural space and then opened. And then the patient aspirates air externally to create a pneumothorax and permit you to conduct your thoracoscopy. So we asked this question, my colleague John Corcoran asked this question 5 years ago. Can we use ultrasound to decide which patients can we safely induce a pneumothorax in for this purpose? So this is what we found. We did 207 thoracoscopies. 1 in 3 required pneumothorax induction, and 13 of those could not be induced. And ultrasound was very powerful at predicting this. So if there was normal lung sliding, then 96% of those could successfully have a pneumothorax induced. In every case where there was poor lung sliding, we were unable to induce a pneumothorax. And in 6 out of 7, we converted them to image-guided biopsy with a good diagnostic yield. So let me show you what that looks like. This is insertion without ultrasound of the Butan needle. So it's being very carefully drilled in until a give is felt. And this is when we presume, without imaging anyway, that we were in the pleural space. This is the trocar is then removed, and one then very carefully listens for aspiration of air with the tap open. If there has been no aspiration of air, the soft version is then placed so that it doesn't cause lung damage. This is screwed into place, and the Butan needle is then put in slightly further So hopefully this doesn't damage the lung. There we are, little give is felt. And at this point, we open up and we can then hear air rushing in and we confirm a pneumothorax. That's how we used to do it. How we currently do it is using ultrasound directly. So this is what we want to see, nice lung sliding. This will allow us to induce a pneumothorax. This patient, there is no lung sliding at all, and this patient will not have a pneumothorax induced. So this is the patient that we would avoid. What does it look like? Well, this is a patient who's got a small effusion, but not enough to put a thoracoscope in. The lung is sliding. We place a butan needle under direct vision, and after placement, this is what it looks like. And you can see that there is a combination of fluid lung and then pneumothorax here. So we've been successful in this case. And here it is live. So this is the upper lobe, this is the lower lobe. I'll just let that play again, actually. And there is fluid, black fluid sitting here. Black fluid sitting here, my butan is here, and this is the pneumothorax being induced as the patient breathes in. So it's a really beautiful direct way of confirming that you can induce a pneumothorax. Okay, what about something para-procedural, so intercostal artery detection? All of you will know the anatomy, and the anatomy we are taught is from the spine all the way out to the sternum. The neurovascular bundle hides underneath the rib, and that's why we hug the top of the rib when we're doing our pleural procedures in order to avoid the neurovascular bundle. Now this diagram is from Gray's Anatomy, the very famous textbook, and it implies that as soon as they emerge from the aorta and from the spine, everything hides nicely under the rib. But in fact, that is not true, and we have proven this to be untrue. So this is a study we did in Oxford 7 years ago. We looked at CT pulmonary angiograms, reconstructed them in the coronal plane, and you can see here the intercostal arteries. And what we were interested in finding was, were they truly hidden under the rib above, or did they move within the intercostal space like this one has here? And you can see the very variable course of the intercostal artery posteriorly. So we measured over 300 arteries, and I'll just explain the graphic before telling you the result. So this is lateral distance from the spine. So 0 is the central spinous process, and this is us moving along the rib. So at this point, you are 5 centimeters away from the spine. And 0 here on the y-axis is the rib below, 100 is the rib above. So anything here is hidden, whereas this is exposed within the intercostal space. And you can see that for the first 6 centimeters, the intercostal arteries are standardly very exposed in those posterior positions. And this, of course, causes intercostal bleeding if you go in here. So the intercostal arteries are very variable, they're very exposed. The question is, can we find a technique to detect them to avoid the horrific problem of intercostal artery bleeding? So there are 2 studies to address in this area. The first is by the Australian group, Salamonson. They did a 50-patient study, and they did a CT. They marked where the intercostal arteries were with fiducial markers, and then they did ultrasound with a cheap and an expensive ultrasound machine in 3 different positions. And they had the CT as the gold standard, with which I agree. And this was them detecting the intercostal artery and then confirming it using power wave Doppler. And this was then with their fiducial markers. And what did they show? They showed that portable ultrasound and high ultrasound had very good sensitivity in detecting the intercostal artery. So it does seem that we have proof of principle that the ultrasound machine in a pulmonologist's hands can detect the intercostal artery. Now, there were several distinct problems with this study. So the first is none of these patients had pleural fluid. They were just patients having CT pulmonary angiograms for pulmonary embolus. So this isn't patients who are going to go on to have procedures. And you and I wouldn't put needles into patients who weren't going to have procedures. So potentially it wasn't very useful. And then the third worrying part is that the ultrasound identified arteries that were different to that on the CT. Different parts were identified. So it showed proof of principle. It showed that the scanning time was very short, 42 seconds or 18 seconds, but nonetheless, it gives us proof of principle that it might work. So what we needed was proof that it worked in an intervention population. And my current fellow, Ihab Badawi, has just published this article in the European Respiratory Journal. It's not in full print yet, but it is available online. So what did we do? We took patients with a standard linear probe, curvilinear probe, and we accessed their intercostal space and looked at it in different planes using standard Doppler. And this is what we did. a total of nearly 600 procedures. We screened for the intercostal artery in 563 procedures. And of those, we identified the intercostal artery in 53% and not in 47%. And then we specifically looked at how often did we change where we were going to place our drain or place our thoracentesis needle according to the ultrasound. And essentially, in about 1 in 3 cases, it altered where we were going to go in. Now, interestingly, this looks at how often we were able to identify the intercostal artery according to the procedure we were doing: thoracoscopy, image-guided biopsy, drain insertion, IPC, therapeutic or diagnostic aspiration. And overall, in 50% of cases, we could identify the artery. This is the more important slide, which is how often did it alter what we did. And interestingly, the image-guided biopsy population had the highest number of exposed arteries that altered what we were doing. And we think the reason for that is that these are the patients with pleural thickening, which causes rib crowding and therefore exposure of the intercostal artery. So we found this particularly useful in patients with image-guided biopsy, less useful for thoracoscopy and yes, useful for IPC insertion, for example. So we've proven that it is possible and we've proven that it's useful, and this is now probably going to be standard care in our hands. I'll just show you some videos of it. So this is a patient without an effusion, and here's the Doppler box, and exactly where you'd expect. Here is the intercostal artery blipping away as you'd expect to see. This is a patient who was undergoing a thoracentesis. They've got ascites and effusion. This bit of Doppler here is the Doppler that you would see with the fluid, but this thing here, this worm-like structure, that is the intercostal artery. This is another example where it's seen both anteriorly and posteriorly, intercostal artery here and here, and this altered where we were going to put our drain. It was going to go here, but we moved to a different site. And then this is an example of patient undergoing an image-guided biopsy of a malignant looking pleural lesion, intercostal artery beautifully exposed just here. We obviously conducted our procedure this side rather than this side to avoid the intercostal artery. And then this is just for fun, really. This is what happens when you don't avoid the intercostal artery, which is a brisk pleural bleed. So just to explain the ultrasound, a couple of things alerted us to this occurring. One is that there was echogenic material gathering within a non-echogenic space, and it seemed to be pluming out. We then put on the Doppler, and you can see evidence of an active intercostal bleed. Now, this was after an image-guided biopsy. This was before we screened for the intercostal artery. Why was this useful? Because we knew about the bleed within 5 seconds of it occurring, and we were able then to apply external pressure and watch very carefully. And actually, with external pressure for 5 minutes, this ceased completely. The patient didn't need any other form of intervention, but we certainly stopped biopsying in this area. So I think it is a potentially very useful thing to do. Now, my last couple of areas are these. The first is, what about unexpandable lung? I think it would be very useful before we conduct an intervention, before we do a thoracentesis, to predict if a patient will have trapped lung or unexpandable lung. And the question is, can ultrasound act as the way of doing this? And again, this is some data from the Salamonson group. They've looked at the use of M-mode and speckle tracking. And the principle is this: you have an effusion here. Here is the lung, which is bouncing with the cardiac pulsation. And maybe the degree of bouncing up and down is a surrogate marker for how elastic the lung is, and therefore how well the lung will expand after aspiration. So we can use an M-mode device here, and this is the lung bouncing up and down with the cardiac pulsation. So does the amount of change tell us whether the lung is expandable? And in their study, they used a combination of M-mode and speckle tracking, which is a much more complex way of doing this. And they found that it does appear to predict the dynamic characteristics of the tissue and therefore whether the lung was expandable. This is 2 examples from my own practice. So these were 2 patients with a right effusion and a left effusion. You can see they look very similar, and we used M-mode in both of them and showed a very big difference in the M-mode. So here you can see that the lung was moving very easily with the cardiac pulsation. Here it's moving much less. And when we looked at which patient was which, this patient did not expand their lung, not much movement. This patient expanded their lung beautifully, with normal movement of the lung tissue. And in fact, we've reviewed this in now 30 patients, and this is what we found. So we divided the patients into whether they were trapped or whether they were not trapped. And essentially movement above 2.5 millimeters on that M mode, the vertical M mode, anything above 2.5 millimeters beautifully predicts that the lung will be fully expansile. So we now have some prospective work to do to see if this works, but this is something that you can do in your own hospital straight away in order to contribute to whether this works prospectively or not. Now, my final bits, ultrasound as a predictor of pleurodesis success. So talc pleurodesis is still very commonly used. We wanted to do a study where we used ultrasound to predict accurately whether talc pleurodesis had occurred, and if it did, could we then get the patient out of the hospital a little bit earlier? And this is the simple trial. And just as fair warning, I'm going to show you some data from a randomized trial, which is not as yet published. So I'd appreciate it if this wasn't shared any further beyond this meeting. So at the minute, what do we do? If a patient has a talc pleurodesis, we use the X-ray and how much fluid is coming out to decide when we give the talc. And then we use the X-ray and less than 250 mils per day to decide to withdraw the drain 48 to 72 hours after giving the talc. Now, what is this based on? This is in the BTS guidelines. This is based on a single study of 10 patients that wasn't randomized. So this is very poor quality data, and yet this is what all of us do. And this is what the BTS guidelines say, evidence grade C. So people have tried to withdraw chest tubes earlier, and this is a randomized trial done in Reading here in the UK, where they tried to answer this question. So they randomized patients to early versus late withdrawal of the chest tube, 24 hours and 72 hours. And they said that there was no difference between the arms, and therefore it was valid to remove the drain at 24 hours. In fact, that's completely incorrect, and this is why. This was a superiority study which was grossly underpowered. So they only achieved 27% of their target, and it seems very likely that this was a negative superiority study because they were underpowered. So in fact, this is not good evidence that we should withdraw the drain after only 24 hours. So we have now completed this study. This is called SIMPLE. We took patients with malignant pleural effusion who needed a pleurodesis. We randomized them to either standard BTS care, so that means 48 to 72 hours, look at the chest X-ray, less than 250 mils per day, and then you could withdraw the drain, versus thoracic ultrasound guided management. So we did ultrasounds on them every day, and then we pleurodesed them, and we looked at two outcomes: hospital stay as a superiority outcome and pleurodesis success as a non-inferiority outcome. This is what we did. So daily, we scanned them in 9 thoracic positions, 3 posterior, 3 lateral, and 3 anterior. And in each position, we scored the lung sliding as present, questionable, or absent. So the maximum score was 27, the minimum score was 9. And when they achieved a score above 20, we withdrew the drain regardless of the X-ray and regardless of how much fluid was coming out of the chest. And this is an example. So here's a patient on B mode and M mode. This was the day of pleurodesis, the day before pleurodesis, I should say. And you can see that there's clear lung sliding both on the B mode and the M mode. This was 24 hours post pleurodesis, and you can see absolutely no movement within 24 hours. So this would score a 3 in that thoracic position. This was our trial flow. We randomized 313 patients and analyzed 149 in each group. So we had very good data completion. I'll skip to the primary outcome results. As I've said, these are unpublished and therefore not peer reviewed as yet, but you can see that using ultrasound, it reduced hospital stay by a whole day with a very positive P value. So it worked. It got patients out of hospital much more quickly than using standard care. So that's good. The question is, was there any damage to the patient? So did they then have higher pleurodesis failure rates? And the answer is they do not. So this is a non-inferiority comparison. Our non-inferiority margin was 15%, and you can see that the confidence interval does not cross 15%, so we can essentially get the drain out one day earlier without any damage to the pleurodesis by using ultrasound. So in my opinion, that means that ultrasound has been proven to reduce hospital stay, gets the drain out more quickly, it does not impair pleurodesis, and it may even improve quality of life. I haven't shown you that data. So we need to get this data published, but if it gets published, then I think daily ultrasound after pleurodesis should be the standard of care in your patients with malignant pleural effusion. So to summarize my entire talk, I think advanced ultrasound by pulmonary physicians is important. It's sensitive for pneumothorax detection. It's useful pre-thoracoscopy. It permits you to do a high yield biopsy. It may even tell you which biopsy to do. In the future, we need to understand the role of intercostal artery screening, pleurodesis assessment, trapped lung detection. In the time of COVID, we will be using it for interstitial syndrome. I haven't even mentioned that, and also for pleurodesis detection. So I must thank all of my co-investigators and all of the studies that we've done, and extend huge thanks to Muzafer Matintash and the organizing committee for honoring me with asking me to give this lecture. Thank you very much indeed for your attention.
It's a great talk. Thank you. Is there any questions from the audience? We have, yes. Sorry.
No, that's fine. I'm afraid I can't translate the Turkish except for merhaba. I know what that means, but apart from that, I don't.
Talat is asking, thank you very much for your very nice presentation. I have a question about malignant pleural effusion. When should we intervene to treat malignant pleural effusion? Is it as it is detected, or when it is symptomatic?
Yes, that's a very good question. So actually, I'm going to give you two very different answers to that question. The first is the received wisdom, which is that we should intervene only when it's symptomatic. But I would make sure, Dr. Talat, that we are careful. A lot of patients, when you first ask them, are you breathless, will say, I'm not breathless. And after you drain the fluid, they come back and say, I didn't know I was breathless, but I feel much better. So that's a very key practice point. Often patients don't think they're breathless, and it's only when you remove the fluid they're breathless. So in general, yes, we intervene on symptomatic disease. However, there is building evidence from our lab and other labs that it may be that pleural fluid acts as a potent growth mediator for malignant cells. And there's basic science data and some animal model data that if malignant cells sitting inside the parietal or the visceral pleura are soaked with pleural fluid, they grow much faster. Now, if that's the case, and it's not proven in humans yet, but if that is the case, then we need to completely alter how we handle malignant pleural effusion. And we need to not use indwelling pleural catheters. We need to aggressively pleurodese patients, and we need to drain even small malignant effusions. And certainly there is evidence from lung cancer that even a small effusion is associated with a very poor outcome. Indwelling catheter patients, I would then be very uncomfortable with just having them sloshing their pleural fluid around all the time. And the final piece of the puzzle here is there is very good data that patients that have successful pleurodesis have a longer life expectancy. Now, is that because there's no pleural fluid, or is it because their pleura is different? I don't know the answer, but it's an interesting area in the future.
Okay, another one is from Nilgün Yılmaz Demirci. Her question is, she thanks you first, and then can strain electrography be used in the evaluation of the pleura?
Yeah, so Nilgün, thank you for the very good question. We have one piece of data that I presented from the Chinese group that it may be useful in evaluation of the pleura. It is possible. Can it be widely used? We need more data on whether it can be used. I think the elastic tissues are probably different in malignancy versus non-malignancy. It's certainly true in hepatic malignancy and renal malignancy. It should probably be the same in the pleura. The challenge is that compared to solid organs, the pleura is a very thin membrane. And is there enough resolution of ultrasound machines to detect strain in that small area? I'm not sure yet, but certainly an area for research.
Okay. Dr. Hüseyin Yıldırım has a question for you. He's our head of department. What are the indications for use of thoracic ultrasound in the ICU?
Yes, so thank you, Dr. Yıldırım. Very good question. I think there are, again, there's two different areas here. The first is the use of lung ultrasound, which I haven't spoken about at all today. And I think that's a whole different talk. And I'm aware that you have people who know more about this than me on the call. So I won't really answer that. I think it does have a role. For pleural disease, I think it is very useful for detection of pneumothorax in a patient who has suddenly become hypoxic, suddenly their ventilation parameters have failed. An ultrasound can be done in less than a minute and tell you if there is a pneumothorax. That's one. The second area is much more tricky, and that is in the assessment of bilateral pleural effusions. And nobody to date has done a decent study on this to understand whether a patient on a ventilator who is having difficulty weaning off a ventilator with small bilateral effusions, would draining the effusions help? I think ultrasound is a great way of finding that out, but nobody has done the study as yet. The other obvious area is patients with who are intubated do sometimes get pleural infection, and I think patients on ICU should be scanned every day.
Okay, from Deniz Köksal, Hacettepe University. She thanks you first. And can you please clarify, do you perform extra intervention when you are making everyday ultrasound control after pleurodesis?
Thank you, Dennis. I'm sorry that I wasn't clear with the answer to the question. No, we didn't do any other intervention. What we were looking for was getting up to that pleurodesis score of above 20. If we got above the score of 20, the only thing we did was remove the drain and send the patient home. There was no further interventions.
One more, and I have one.
Of course.
What is the role? What is the role of thoracic ultrasonography in parenchymal infiltrative disease as COVID pneumonia?
Yeah, that's a great question, Sonai. Thank you. I think, so if you go to the literature, there is lots of data on people using ultrasound all the time for COVID. Okay. My problem is this, and I'll share it with all of you on the call. COVID pneumonia is not a difficult diagnosis to make. We're in a pandemic, the chest X-ray is typical and the CT is typical. So to say that ultrasound can be used to help our diagnosis is a very high bar. It's very difficult to get past. So for diagnosis of COVID pneumonia, unless you're in a place that can't do an X-ray or can't do a CT scan, I think it's not a useful test personally. I think the interest is whether it can be used to predict which patients are going to have a bad clinical outcome. And there is some data emerging that having multiple B lines early in treatment can predict the oxygen requirement 2 or 3 days later. That's the study that needs to be done. And to my understanding has not yet prospectively been done. That's the study I would do, but hopefully, inshallah, we won't see too much more COVID-19 pneumonia.
Okay, I have a question.
Yes.
After non-specific pleuritis by MT, we follow the patients by CT every 3 months for a year or 2 years. Do you think we can follow the patients by ultrasound for the malignancy, especially mesothelioma?
Yes, I think that's a beautiful question. Thank you. Good to do. In fact, that's what we do in Oxford. We don't follow them with CT, with certain exceptions, and I'll explain the exceptions. If they've developed weight loss, chest pain, or worsening symptoms, we will do a CT. But otherwise, we see them every 3 months with an ultrasound on the understanding that the ultrasound is very carefully documented. And when I mean documented, I mean we have measured the pleural thickening and we have kept videos that are available on the PACS system so that the next person 3 months later can compare. It's no good me scanning today with no images, and then my colleague sees them 3 months later, and all he can read in my letter is ultrasound looked okay. If we're going to use it as a monitoring test, we have to use the same standards as the radiologists. And I therefore think that we need to use ultrasound in that way. So in Oxford, we universally follow them with ultrasound, and we only CT them if they have symptoms or the ultrasound changes.
Thank you.
Najib, thank you very much.
Yes.
It is a very nice lecture for us. I am sure that your lecture will be useful for our future research and future clinical practice. Thank you very much.
I hope so.
Then
my great pleasure.
The number of participants reach it to 54. It will be a good participant numbers. I saw that the use of ultrasonography is getting larger in pleural practice. For example, can it be useful, the diagnosis of asbestos-related pleural diseases? For example, pleural calcification, irregular pleural thickening, rounded atelectasis, or asbestosis with pleural thickening and interseptal thickening. It will be useful for this problem.
Yes, so Muzaffar, thank you. I think it is useful for that problem. We should, now look, I love ultrasound, it's a wonderful technique, but it has limitations. And one of its limitations is that to do a proper ultrasound, you have to really look at all the thoracic areas. And I think in pulmonologists' hands, often people just scan one area and then they finish. And this is not a proper ultrasound. So that's the first limitation. Comparing it to CT, CT gives beautiful 3D images, which we don't get with ultrasound. But to directly answer your question, you can see pleural calcification on ultrasound very easily. You can see benign pleural thickening. You can see asbestosis. You can see rounded atelectasis. For sure, it is useful in the diagnosis and management of these cases. I think our experience in this area is building. And I think at some point we might say we don't need to do CT, we'll just do ultrasound, or maybe do a baseline CT and then follow with ultrasound. I think that's probably what I would do.
Yeah. Another question. I can't remember that. Is there any study comparing ultrasonography with computed tomography for diagnosis of malignant pleural diseases?
So, Muzaffar, the only one is the study that we did back in 2005, which was, so Nagmi Qureshi was the first author, and that was a prospective study using ultrasound and then CT and then ground truth diagnosis. But it was a small study, only 52 patients. So it should be done again, it should be repeated. It would actually be quite an easy study to do. The key thing is to blind the operator to what the diagnosis is and then find out later. But other than the one that we have done, it hasn't been compared, no.
Yeah. Najib, thank you very much.
My great pleasure.
I hope we see together face to face.
I would love to see you all face to face very soon, hopefully when all of this pandemic is over. It's been my honor to see you. Thank you so much.
Inshallah.
Thank you.
Inshallah, inshallah. Thank you. Nice to see you. Take care.
Thank you very much.
Take care.
Take care. Take care. Assalamu alaikum.
Bye-bye.
Thank you very much for your good presentation.
Bye-bye. Thank you, sir.
I stopped the presentation.
Okay.
Thank you.
Bye-bye.
Bye-bye.